Go ahead.
Good morning, everyone. We're starting a little early because today we're awarding the Physician of the Year. So this is an honor that Sarah and I are. So I'm Lonnie Anderson. This is Sarah John. We are the co-chairs of the Nursing Experience Council for Primary Children's, and as in that role is our honor to nominate or to go through the nominations that we receive for Physician of the Year. And so and we'd like to thank everyone that nominated somebody and congratulate everyone that's been nominated. And also thank you to those of you that were not nominated. I'm sure you all have done so many amazing things and we only have time to recognize so many. And so here we go. Oh, and also we have like what I think 20 to 30 slides to go through. So please, if you're going to applaud, please make it quick. Because we have 10 minutes, so do the math on that, how many slides we get to go through. So our nominees, starting, oh, did you want to be the first one? First nominee is Dr. Benjamin Kalm. So, and we're going to read a little thing from each of the nominations. I have worked with Dr. Kalm many times over the last 2 years, especially with trach vent patients. I especially love having Dr. Kalm as the attending for these chronic trach vent patients because he makes sure he gives the patient family the best care, and when something is off, he immediately finds a solution to solve the problem. He's extremely calm and level-headed. Even in stressful situations, he is very gentle in his care.
Our next nominee is Dr. Brian Flaherty. Brian is very deserving of this recognition. He is an amazing attending in the PICU. He cares so deeply about every patient. The nursing staff feels comfortable asking questions and voicing concerns to him. He allows for all learning opportunities, accepts all questions, and allows his peers to learn. He is a calming presence in the chaos and handles all situations thrown at him in the PICU.
Dr. David Bailey. Dr. Bailey is an example of integrity in the way he is passionate about doing right by the patients we serve. Dr. Bailey often sets the example of bringing up the conversation by asking if this is the right thing to do for this patient and their family. He advocates for more conversation and slowing down to make sure things are not being rushed when it comes to decisions.
Dr. Erin Avendet. Erin goes above and beyond to work as a team with the nurses for the patient's benefit. She advocates for children in social media and outside of work. She is knowledgeable and a great teacher. She's also fun to work with.
Dr. Frank Cipriano. He does not back down when from something because it is hard or not working. When it is the right thing to do, he will do it. In his discussions with the nurses on 3 Northeast, he is willing to do hard things or have difficult conversations with us and others when needed, but he is always kind and patient when doing so. He cares, he respects our opinions, and he is helpful.
Dr. Jenny Workman. She has a passion for what she does. She doesn't seem to tire doing what's best and ensuring that best practices are in place. She is eager to review and learn. She has been instrumental in encouraging teams to follow through and complete the sepsis bundle elements for the best outcomes for each patient.
Dr. Jeremy Meyer. This month I saw a 6-year-old patient for swallow study and was able to give the happy news to the mother the child's swallowing problems had resolved. In that joyous moment, the mother shared with me her memories of her child's early days in the NICU and how she had been so terrified. This sweet, sensitive mother explained, Dr. Meyer would come and sit with me to make sure I was okay and not afraid. Can you believe that? With all that he had to do, he really cared. And he really does. The families tell the true story. Dr. Meyer is the ultimate example of the child first and always.
Dr. Kevin Jones. Recently, Dr. Jones had a patient fly in from out of state that had a spinal cord tumor needing urgent surgery. The family got to the airport and found they didn't meet qualifications to rent a car. In an unfamiliar state, overwhelmed with everything happening to their child, they reached out to Dr. Jones for help. He went to the airport himself to pick up the patient and family and get them to the hospital.
Dr. Lucy Hanson. Not only is she a great resource for our staff, but she is an even better resource for our patients and families. She takes the time to print out the LTAs and deliver important education to them so that they can better understand their child's diagnosis. Regardless of how busy the day is, she will sit with families at eye level and stay in the room until all questions are answered and everyone feels comfortable with the plan of care.
Dr. Michael Mallory. Dr. Mallory is wonderful. He has a fantastic leadership skills, collaborates well with the team, is professional, and has a great bedside manner. He is proactive and fully involved in patient care. He is often the first caregiver in the patient's room and is quick to begin treatment. He communicates well with the entire team and is passionate about providing the best care possible.
Dr. Peter Grubb. While rounding on patients for the day, the parent of one of his patients expressed frustration and confusion about the overall plan for his child. They had come close to coming home several times, only to have sudden escalation in care thwart the plan. This parent didn't understand what was holding up the discharge, especially after hearing from consults that all was well. Dr. Grubb immediately stopped the rounding and spent time with them. He calmly listened to the parents' concerns and then carefully explained the concerns the NICU team had that were preventing a safe discharge to home. He methodically explained his plan to discover and resolve the underlying issues. By the end of the conversation, this parent knew why the NICU team was concerned, what we were trying to do to resolve the issues, potentials for delays, and our mutual plan for safe discharge to home. The parent felt heard and acknowledged.
Dr. Priya Chan. Priya shows up to work every day and always puts forth her best effort. She ensures that every patient that she sees leaves their appointment feeling cared for and heard. How she carries herself in her daily patient care and bedside manner reminds the entire care team of our why. Priya's actions showcase that she is her patient's biggest warrior and is there to help them and their families every step of their treatment process.
Dr. Quinn Orb. We had a patient that we saw around April who was planning to go to her high school prom. She and her mother both voiced some concerns about her trach and being away from home and family for a few hours. She was very excited to go to prom with her friends and be a normal teenager. Dr. Orb gave the patient his personal cell phone number and told her if she had any questions or issues during the date, she could call him and he would be happy to help her and even drive to where she was if she needed him. I could tell this gave the patient and her mom some hope and relief and happiness. The patient had no issues on the date and sent Dr. Orb pictures of her and her friends at prom. She was very happy.
Dr. Spencer Mangum. Dr. Mangum is amazing. He is a fantastic teacher and always takes time to explain pathophysiology to students and colleagues alike. He teaches in a way that isn't condescending or intimidating. He cares deeply about the well-being of his staff and his patients and is genuinely one of the kindest people in the service line. He has taken time out of his very busy day to ask other coworkers how he and others can make the work environment better for everyone, so that it is a psychologically and physically safe environment for all. Dr. Mangum has such a great attitude and is a wonderful person to work with.
Dr. Whitney Hogan. We had a fetal heart patient that was Muslim and a female sonographer was unavailable, so Dr. Hogan stayed an extra hour to both scan and consult the patient. She helped this patient feel safe and comfortable so she wouldn't need to reschedule her appointment.
Dr. Bar Devald. I can't say his name without smiling, even if he calls and our unit is completely full and is like, I have an admit. The way he says it, we'll happily take the admit, always. Dr. Devald was described by caregivers as thoughtful, hardworking, and kind. He is always willing to help nurses and other members of the interdisciplinary team. One charge nurse stated, "Not every fellow remembers nurses' names, but Bar does. He also remembers specific details about nurses. He makes us feel like valued members of the team." Another charge nurse said, "I appreciate that Bar remains calm and level-headed in the most stressful emergent situations. He is a true leader."
Dr. Carrie Phillips. She is so kind and thorough with with patient care. She takes the time for our population of cardiac kids to ensure that we are not becoming complacent on new norms for their stay. She ensures no test is unturned and no patient is left suffering in pain and discomfort with proper uses of pain relief. Dr. Phillips takes time to get to know each patient as a person and advocates for them in every way imaginable. Dr. Phillips is exceptional, and we are so lucky to have her here at PCH.
Dr. Candy DeMundo. Throughout her fellowship, Dr. DeMundo has been caring and compassionate to all patients within her care, even the patients that are deemed difficult by many members of the healthcare team. One particular patient has a very challenging social situation, leading to behavioral issues. Dr. DeMundo sees past these issues and always treats this young man with kindness, love, and respect. She has put in so much work to make sure he is safe at home and is receiving the care he needs. Her care for this patient is truly admirable.
Dr. Kasia Vlasic. Kasia was instantly a team member and competent provider. She is clearly knowledgeable but humble in the care she provides. She does not hesitate to step into any situation and address the issue professionally. She is so smart, on top of things, and isn't afraid to ask for help. She has the best attitude, is very friendly and approachable. She is very talented and always willing to help others. She is very skilled and takes wonderful care of patients and their families. I love it when I get to work a shift with her because I know I'm going to learn so much and also have a lot of fun.
Dr. Marlena Desprez. She is a caring and wonderful provider. We appreciate everything she does in the echocardiography lab.
Okay, so now we're going to present the winners.
Please cheer for these people.
Yes,
and
please.
If you are here, come up. We have some things.
And we want to embarrass you a little.
Yep.
Okay. Dr. Abby Halm. We worked together on a patient that was, yay!
Yay!
And if you're here, We worked together on a patient that was very challenging physically, mentally, and emotionally. I feel like she and I made a really good game plan during rounds, and then she stuck to that plan day after day. Sometimes the doctors will say they are sticking to a plan but don't, but Abby did, and it was really cool to work with her.
Dr. Erin goes camp. Erin is one of my favorite fellows to work with. Oh, yes. When I see her on my shift, I know the night will be a good one. She is always willing to listen to my concerns and lets me ask questions about the care of my patient, or even just a learning question for myself. She is never one to shame for asking questions and answers them. She always answers my vocera calls and is quick to come to the bedside when needed. She cares so deeply about every patient and handles any situation thrown at her with grace. I cannot say enough about how much I love working with her. I hope to see her as an attending in our PICU.
Dr. Andrew Chevalier. Chevy is a constant breath of fresh air in both units. He brings lightheartedness that is hard to find at times within the train of sadness that our units can become. Chevy is great at ensuring he uses people's names when talking with them. That includes nurses, parents, other physicians, and whoever might come through the unit. Chevy truly cares about the patients and has great discernment when it comes to patient needs. He has a great rapport with the staff and is always willing to listen. He is quick to close loops of communication, and it is appreciated that he always uses people's names when addressing them. This creates a thriving unit when he is on shift. He is truly a light for the unit.
Dr. Scott Short. I have worked with Dr. Short for a long time, since he was a fellow, so I have seen him interact with patients and families at the bedside quite often. He is always very thoughtful in his interactions. He addresses every question a family may have, no matter how often they ask. I have also seen him come back to the bedside to address patient and family issues, which is very difficult with the busy OR schedule they keep. Dr. Short is compassionate in the care he gives, especially when families are facing unexpected, difficult diagnoses. I appreciate the thoughtful way he approaches families, and I know they do too.
Dr. Vandana Raman. Dr. Raman is always reaching out to the community and trying to find ways to improve diabetes management in schools and homes where families struggle. She created the DIME, Diabetes Intensive Management and Education Program, to lend more support to families with difficult socioeconomic concerns. Often these families are struggling to put food on the table. They have a difficult time problem solving and frequently are admitted with DKA, diabetic ketoacidosis. The DIME clinic meets with these families every other month, where they see Dr. Raman, a diabetes educator, a social worker, and have a 1-hour therapy session with a psychologist. Weekly phone calls and texts are initiated, and over time, these families come to trust Dr. Raman and her team. This program changes lives. Families tell us that not only is their diabetes control improving, but family stress decreases significantly, and their overall outlook at life is improved forever. These families are so grateful for the support, lack of judgment, and understanding that Dr. Raman provides them.
Dr. Amanda Johnson. I know she's here. You can come on down. Yeah, she's here. You can come on down and get your prizes.
She has a fan club.
Oh. So there were so many stories about Dr. Johnson. It was really hard to choose, but this is the one we selected to share for this meeting. It's from one of our charge nurses that works night shifts. I met Dr. Amanda Johnson when I was charging on a night shift. It was one of her first weeks here at PCH, and one of our beloved teenage bone marrow transplant patients was dying. The nurses and PCTs had watched the sweet boy endure excruciating side effects from his cancer and treatment for months. He had been told he would not survive many more days and chose to stay in the hospital to pass away surrounded by his family and the caregivers who loved him. We were heartbroken. Amanda not only treated the patient and his family with the utmost respect and compassion, but she also checked in with the nurses, empathetically listening and comforting us as we grieved. She sat on the pod with us late into the night, ensuring we had everything we needed to care for this sweet boy. Being a new bone marrow being a new BMT attending, she never hesitated to consult with other providers when questions arose of how to keep the patient comfortable. I was impressed with Amanda from this initial meeting and continue to be amazed by the outstanding care she provides patients and families, and by her respect, not only for the nurses, but the entire interdisciplinary team. Congratulations.
Congratulations to everyone, and enjoy Doctor's Day coming up, and thanks for letting us do this.
We really appreciate all of you. Thank you.
Just start. Okay. All righty. Good morning, everybody. Good morning and welcome, and thank you for coming to Pediatric Grand Rounds. I am Allie Armstrong, one of the Pediatric Chief Residents. Today's Cloud CME claim credit code is 33019. Online questions, please go in the live chat. For those in the auditorium, just raise your hand at the end, and we use overhead microphones for your questions. All righty. Now to introduce our speaker, Dr. Philip Spinella. As an introduction, Dr. Spinella is a professor in the departments of Surgery and Critical Care Medicine, co-director of the Trauma and Transfusion Medicine Research Center, and associate medical director of the Center for Military Medicine Research at the University of Pittsburgh. He is internationally recognized as an expert in transfusion medicine and the resuscitation of hemorrhagic shock. Dr. Spinella served 15 years in the U.S. Army and separated as a lieutenant colonel in 2007. He is a veteran of the Iraq War, where he received a Bronze Star and Combat Medic Badge for providing care under fire. In collaboration with investigators at the U.S. Army Institute of Surgical Research, his groundbreaking work in the area of treatment of hemorrhagic shock received the U.S. Army's Best Invention Award in 2008 for his role in the development of the concept of damage control resuscitation. Dr. Spinella is a well-established clinical trialist who has been funded by the U.S. Department of Defense and the National Institutes of Health for trials examining red blood cell storage, age, tranexamic acid, and cold-stored platelets. He has published over 292 manuscripts and 22 chapters and is the editor for a textbook on the topic of trauma resuscitation. Dr. Spinella has also participated in organized research symposia for or provided external review of research programs for the FDA, NIH, DoD, Homeland Security, and Department of Health and Human Services. He has also participated on a committee for the National Academy of Sciences to develop recommendations for a national trauma system in the U.S. Dr. Spinella co-founded the Thor Network and has been its co-director since 2011. Through this network, he has hosted training and educational programs in over 12 countries in 4 continents. The network has also performed groundbreaking research related to whole blood and platelet transfusion for traumatic bleeding. Please welcome Dr. Spinella.
Well, thank you for the very kind and generous introduction. I guess you got to be careful what you put on the internet, right? People can find anything about you. So it's great to be back here. I was maybe here 10 years ago or so, give grand rounds, and it's great to see many people I've worked with in the past and actually a lot of people I'm hoping to work with in the future. I do want to thank the chief residents as well for inviting me out to give grand rounds as well as the department. So this morning I'm going to talk about pediatric hemostatic resuscitation, kind of give you an overview of the state of the science right now, and there's a lot of data emerging, as well as trials that are in development or have started But at the end, I really want to focus on when to change practice, right? Because the big conundrum for all of us, right, especially for those that deal with critically ill children, but no matter what your specialty is, as data is being generated, when is the time to pull the trigger, so to speak, and change practice? If we always wait for a trial to be done, we're waiting a long time, sometimes forever, for that trial to be done. And I really want to be able to focus there. So I'm going to stop babbling and get into the slides. Here's my disclosure slide. Yeah, that's what it is. So hemostatic resuscitation is a blood-based resuscitation for patients with hemorrhagic shock, but it's part of a larger bundle of care called damage control resuscitation. This was a term coined by John Holcomb back in 2007, and it's a large bundle of care, again, aimed at improving outcomes for patients with hemorrhagic shock, primarily for traumatic hemorrhagic shock, but now we're starting to apply these DCR principles to include hemostatic resuscitation in other cohorts than patients with traumatic bleeding. Now, this is important because obviously patients with life-threatening bleeding have a very high mortality, right? In adults, it ranges between 20 to 24% at 28 days, but in children, right? And this is from a prospective observational study that we did, and actually you all participated in. Children have 37% 28-day mortality with life-threatening bleeding. Operative cases, 24%, and medical etiology of massive bleeding, 62%. So why are children having higher mortality from life-threatening bleeding than adults? I think I have some hypotheses, and we'll get to that later on. So hemostatic resuscitation isn't anything new. Kind of it's what we were doing in World War I, World War II, Korea, Vietnam, but it went away in the 70s for multiple reasons. Maybe we can get into that later. It's kind of a whole lecture in and of itself. But we were reintroduced, to a whole blood-based resuscitation early in the war. When I deployed to Baghdad in 04, 05, I had just gotten out of fellowship from CHOP in Philadelphia, where I trained. And there, we were using whole blood daily. I used it all the time in our cardiac ICU. So for me, it was a standard blood product. I didn't think nobody else in the country basically had access to it. So I show up in Baghdad, and there are soldiers bleeding. It was in April of 04. It was just when Fallujah went to hell. So we had a ton of casualties. And I started saying to the team, hey guys, because it was all guys there at the time, where's the whole blood? And they looked at me like I was nuts. I mean, people still do that often for other reasons. But this time, they were like, what do you mean whole blood? I'm like, yeah, whole blood. Like, I use it every day at the Children's Hospital in Philly. They're like, yeah, we don't have that here. I'm like, we need to get it because it helped a lot in the cardiac ICU, and I think it would help our soldiers. Long story short, we got the team to start doing warm, fresh whole blood collections. Basically, I stuck out my arm, donated whole blood. We did do rapid testing for HIV, Hep B, Hep C there at our institution. It wasn't always done because of availability of the kits. And during that year, we realized we were doing something special. We were treating patients with just saline and red cells and plasma eventually. When we started using whole blood, there were major differences in resuscitation of shock and coagulopathy and outcomes. It led to us publishing this paper that kind of reignited the interest in whole blood. It's a retrospective study of 250 patients in general, but those that received whole blood, warm fresh whole blood as part of their resuscitation had an independent association with improved outcomes compared to those that received only components. So this was the beginning of the rebirth of hemostatic resuscitation. At the same time, we were also looking at ratios of components that we're giving to casualties too. I actually gave this paper to Matt Borgman, who was a second-year resident of mine while I was staff down in San Antonio, because I was focused on the previous paper. And this one is one that blew up the most, I guess you could say, because whole blood wasn't available to us in the States until 2015, 16, 17. This paper showed that giving a higher ratio of plasma and platelets to red cells, basically approximating whole blood, right? We were doing this as we were waiting for whole blood to be collected from donors in our hospital. And this also led to kind of the current standard of care, I think, around the country developed world to give components in a 1-to-1-to-1 unit ratio. And then, so that's kind of the underpinning of the background of where this all started from. But it's also important to remember too, right, for patients with life-threatening bleeding, they're dying fast. I showed you in that previous slide, within hours, 3 to 4 hours is when the median time to death. So time is money here as well. Here's just data quantifying that. This is a secondary analysis from the proper trial, the adult ratio study that was done. And basically what this says is that every 1 minute delay in getting any blood product to a patient with traumatic life-threatening bleeding, a 5% increase in mortality. So we all know delay in care, massive bleeding is going to be harmful, right? But this quantifies it. And this has been replicated in the literature, even for pre-hospital resuscitation too, where there was for every 1 minute delay pre-hospital, 2% increase in mortality. And that kind of makes sense because you're getting them earlier. So when it comes to hemostatic resuscitation, what are your options? Well, you can definitely start with an empiric approach. And many centers are now transitioning towards a goal-directed approach with viscoelastic testing, whether it's TEG or ROTEM, and then there's other devices that are coming on the market too. Our practice is to start empiric because you don't have time yet to get those results back, and then quickly transition to a TEG or ROTEM-based approach to facilitate kind of a personalized, transfusion medicine or resuscitation. But what are you going to use, right? And I think either in the U.S. and kind of around the world, centers are either going with components in a 1-to-1-to-1 unit ratio, or, as I'll show you later, the use of low-titer group whole blood is exploding across the country and around the world. There are some places in Europe, I just wanted to be complete, that prefer not to use plasma, so they go with factor concentrates, PCCs, fibrinogen concentrates, and TXA, and do their best to avoid blood products. But then you need volume, right? These patients that are bleeding to death need volume, and that third approach I don't advocate for. The Germans and Austrians do. So when it comes to the adult data, I'm going to very quickly just mention, for adults, the data clearly shows that pre-hospital use of plasma and red cells improves survival. In-hospital use of high ratios in plasma and platelets also have been shown to reduce death from bleeding. In trials, whole blood is associated with improved survival. TXA, many RCTs showing improved survival in adults. Cryoprecipitate versus fibrinogen, the data is variable because the quality of the trials are variable, and that's kind of my bottom bullet there. When you look at the literature, how these trials are done are really essential. You just can't read the abstract, and you have to understand the methods to get a sense of the quality of the data. And then, of course, I think it's been very clear too that the use of crystalloids increases the risk of death in those with life-threatening hemorrhage. And that's kind of a major problem, especially pre-hospital. If you're not able to get blood on your helicopters and even all of your ambulances, which is even harder to do logistically, giving crystalloids to these bleeding patients, you're actually potentially making them worse. And there's RCT level data supporting that. In non-trauma adult data for life-threatening hemorrhage, there's also data in postpartum hemorrhage that TXA improves survival and fibrinogen concentrates are non-inferior to cryo. So that's the non-trauma data in adults. But, we're here to talk about kids. So should we be applying these data to children? And then we have to think about trauma versus non-trauma etiologies of massive bleeding in children. So when we asked ourselves this question maybe about 10 years ago, we said, well, the first thing we need to do is learn more about life-threatening bleeding in children. Who is it occurring to? What are they getting? And what are their outcomes? So that led us to get NIH funding to do the first MATIC study, massive transfusion in children, where we did just that. And again, the goal was to eventually inform future trial design. We did this prospective observational study back from 2014-18, 25 centers. You were one of them, thank you. And we prospectively collected data. And we divided patients into 3 different groups: traumatic etiology of bleeding, operative, and medical causes of bleeding. Here's just the paper. And what was interesting is that while trauma was the most common, it wasn't the majority of patients. 44% of the life-threatening bleeding in children was from trauma. 36% was operative, 20% was medical. The operative was mainly cardiac surgery, some liver transplant, mostly, and the medical were children with oncologic disorders that developed DIC or had GI bleeding. But then there are differences between the three groups, right? Male predominance for trauma, operative, they were younger, cardiac surgery, and in the medical patients had the highest mortality. So when it comes to the timing of death, this is also very important for us to understand if we're going to start to design trials. You can see here that death from hemorrhage, right? And if you're going to study hemostatic resuscitation, the goal is to reduce death from hemorrhage. The timing of death from hemorrhage, most of it occurs within the first 6 to 12 hours. They all die from hemorrhage within the first 24 hours. It's also interesting to note that the death from CNS injury actually was occurring at a more frequent rate than we thought it would in the first 24 hours. And when we first started thinking about this, we said, oh, geez, this might dilute the signal, right, of hemostatic resuscitation interventions in massively bleeding patients. But actually, there is now RCT level evidence showing that plasma improved outcomes for patients with TBI. And they may have to do with repairing the endothelium, the blood-brain barrier, reducing secondary brain injury. So now, you know what, that's okay. Because maybe the blood products for these patients may also reduce death from CNS injury as well. The patients are different. They have different, this is at the beginning of their life-threatening hemorrhage. So these are massive transfusion protocol activation labs. The trauma patients are more acidemic, have lower fibrinogen concentration. The medical patients are definitely more anemic, thrombocytopenic, and have higher INR. So they are starting from different places. They all, I think, go down the same route pathophysiologically, but they do start from different places. So here, you can see that we're still, back then, 14 to 18, giving, I think, way too much crystalloids. This is during the MTP activation. So after the MTP was activated until the time it was ended, that's what this data represents. And as they're massively bleeding, they get a decent amount of blood per kilo, but look at the amount of crystalloids per group. And it's interesting, the best ratio of blood to crystalloids was in the operative group, not in the trauma, where the data is generated from. But this is why I think kids have a higher mortality. Look at the time, the median time it takes to get plasma and platelets to children with life-threatening bleeding, no matter what the etiology. The median is anywhere between 30 to 43 minutes. And then if you want to look at the 75th percentile, right, 25% of children in this study were getting their first plasma, first platelet at 75 to 111 minutes. That's crazy, right? I mean, it's this delay in recognition leads to then a delay in care. And this is what we have to address in the pediatric community. Better recognition and then faster time to treatment. And I'll talk a little bit later, when it comes to whole blood, it's a lot easier to get it out fast and into the patient than components. We did look at, so in the Matrix study, we did look at ratios. I'm going to go a little bit faster because I want to spend time at the end. We basically showed that ratios, or the deficit of plasma and platelets to red cells, was independently associated with improved outcomes for children with traumatic bleeding. Other retrospective studies have shown this too, so this is evidence that in children with traumatic bleeding, maybe targeting a 1-to-1 ratio is a good idea. Conversely, we looked at the non-trauma patients, and guess what? In the non-trauma etiologies, a 1-to-1, higher ratios or lower deficits did not improve survival. Were not associated with improved survival. Now, you could say small sample size, underpowered, or it could be that in this population, platelets and plasma relative to red cells doesn't make a difference. I don't think this means whole blood wouldn't make a difference. We have to study that too in this population, because here the platelets are stored at room temperature, and we're going to get into that later too. Storing platelets at room temperature leads them to be less effective. We then looked at our database and looked at antifibrinolytics. The children that received, the number of children that received TXA, tranexamic acid, and Amicar were both pretty small. Actually, it was interesting. Factor 7A was still more common in 2014 to 18 than the antifibrinolytics were. In pediatrics, we're about 10 to 15 years behind the adults when it comes to changing practice when it comes to hemostatic resuscitation. But we were interested in looking at antifibrinolytics, and Amicar and TXA groups were too small to analyze individually. So we just combined them. and compared children that received an antifibrinolytic to those that didn't. And after we did our adjusted analyses, those that received either TXA or Amicar, no matter what the etiology of bleeding was, had an independent association with improved survival, which does correlate with the adult data, at least on TXA. So this now helps us focus our interest on TXA moving forward too. And I say TXA because in the trauma literature, that's the only antifibrinolytic that has been studied. I know in our community, at least in the cardiac ICUs, right, Amicar is used more commonly. It's what I use as a fellow too, but TXA is becoming the drug of choice relative to Amicar. And actually, I don't have a slide here, but we looked at the database. Amicar led to more renal dysfunction in our cohort compared to TXA. That was another, and actually there has been some hint of that in the past. And then we also looked at cryo. Early cryo in this population, no matter what the cause of etiology, was also independently associated with improved survival. All right, now we're going to move on to whole blood from a different data set. Christine Leeper out in Pittsburgh. She was one of the main reasons why I left St. Louis to go to Pittsburgh 2 years ago to work with her. She's been pioneering the study of whole blood in children. And here in this earlier study, she showed that when whole blood was used as part of the resuscitation, because it's never the complete resuscitation because the volume of whole blood is often hard to get to give it completely. Faster resolution to shock and better reduction of INR. So shock and coagulopathy seem to be better resolved with whole blood compared to components in this observational study, retrospective study. And then they added more patients, and after adjusting for confounding variables, single center retrospective study, whole blood associated with improved survival. So this was the first hint in children with traumatic bleeding that whole blood may improve outcomes. There had been, by this time, 10, 20 papers in adults showing it was associated with it. The group in Houston, they have the largest volume of trauma MTPs in children in the country. The Houston group just reported something very similar too. I didn't show in the past, the odds ratio for reducing mortality was 0.23 at 72 hours, 0.41 at 20. So a very strong independent association, right, based upon the adjusted analysis. Same thing, they modeled it for survival, and they have a 2.5. So the bottom line is we're getting strong results. Granted, retrospective or observational studies, but well-adjusted studies are showing a strong signal in children, which again mirrors the adult data. Actually, the adult data has the same magnitude of potential effect in their studies. So now we've also started to think about the dose. I've hinted now a few times, and I keep on saying whole blood is part of the resuscitation. Because when these kids are massively bleeding, sometimes they're getting components before the whole blood comes. Sometimes the whole blood comes and you run out of it. Some centers have a maximum amount of whole blood that they're allowed to use in a child or an adult. So when that max is used, then they have to go to components, which has always been a very bizarre concept to me. Now that we've pretty much, I think, shown the safety of Group O whole blood to truncate a therapy that you've started because you thought it was better than the standard. Regardless, most patients, adults or children, only get whole blood as part of their resuscitation. So we, again, led by Christine Leeper, looked at the TQIP database. TQIP is a trauma quality improvement process database. It's basically the national trauma database now, and they collect blood data for the first 4 hours, which isn't that bad in the end because the median time for the MTP activation in children is between 2 to 3 hours. So 4-hour blood product use is adequate. And you can see here, again, in this very large cohort 2, when whole blood was given to children, independent association with improved outcomes at 4 hours and also 24 hours. But the dose matters. Right? This is what that graph shows you. And for every 10% increase in the ratio between whole blood given to total transfusion volume given, a 9% decrease in 24-hour mortality. And that makes sense, right? If you're going to give more of something that is potentially better, you could have a larger effect size. And this has been about to be published in adults too. So it's important when you look at the literature, you have to look at how much whole blood was given, right, in that study to kind of get a sense of interpreting the outcomes. So I cannot go through all the whole blood data. It would take me days to do. So Christine, again, led the group out of Pittsburgh to do a meta-analysis of all of the low titer Group O whole blood data so far. There is some data, like I've showed you mine on warm, fresh whole blood. There's some data with whole blood where people added platelets. We excluded all of that. This is only cold stored low titer Group O whole blood. 24 studies, close to 60,000 patients, 5,000 received whole blood. And in this meta-analysis, again, we see a signal for improved 24-hour survival as well as in-hospital survival too. And I don't have the forest plots for adults versus children, but the same effect size in adults versus children and also statistically significant. So the data is just, continuing to grow to indicate that there might be a survival advantage with Group O whole blood compared to components in both children and adults. But what about safety? Because if you're going to consider changing practice, you have to think about, is this a safe product? When you use Group O whole blood, right, low titer Group O whole blood, the low titer should help with any potential risk for hemolysis. And Group O is going to prevent the risk of a fatal transfusion reaction from an ABO mismatch. So actually, it's fairly safe. This is data, again, from children showing really no difference in hemolysis metrics for children who were Group O versus non-Group O, right? The non-Group O children are at high or would be at risk of hemolysis, and really no difference there. We've looked at organ failure in children too, no difference between the Group O versus non-Group O recipients. To be completely transparent and honest, these studies are with a maximum of 40 mLs per kilo, right? The pediatric studies yet, even the Houston study didn't have a large volume, a large dose given. But in adult studies, we have looked at this where there were up to 8 units of whole blood given to adults and no risk of hemolysis in the non-Group O recipients. So it seems to be fairly safe. And I want to remind the group, right, especially that we're a pediatric group here, and I told you my experience with whole blood was from cardiac surgery. This was a randomized controlled trial published in 1991 by the group out from CHOP, showing in children with complex cardiac surgery, when they received cold whole blood compared to 1:1:1 back in 1991, there was less blood loss or less chest tube output in those children receiving cold whole blood. There are other studies out there that didn't show a difference, but they didn't use whole blood in both the OR and the ICU. This study did both the OR and the ICU. So again, methods matter. So we've had RCT level evidence for whole blood in children for decades, but it's kind of been buried within the transfusion community, until the war started. So how am I doing on time? All right, not bad. I would love to be able to go through all the science, right, behind the biologic rationale for whole blood compared to components. I don't have the time, but I'll summarize it. When you compare low titer Group O whole blood to components, right, which is 1 unit each of red cells, plasma, and platelets, the whole blood itself is more potent because you don't have all the additives and anticoagulants. I'm going to show you a slide next to hammer that point, but it's a more potent product. There are cold platelets in the cold stored whole blood. We've known since the 60s, okay, that a cold stored platelet has more hemostatic function. And I'll explain why we're not using cold platelets when I get to that part of the lecture. But there's improved hemostasis and there's RCT level evidence for that back in 1973. I think I'm going to show that slide. Now with whole blood, you can store it for at least 21 days. Some are using it out to 35 days if it's not leukocyte reduced. So now you have a platelet-containing product of increased storage duration that you can put at the non-medical centers. I don't think you realize how lucky you have it. You have platelets in your medical centers because you can absorb or deal with the inventory effects of having a product that only has a 5-day shelf life. And by the way, it's really 3 days because it takes 2 days to do the infectious disease testing. So you can buy a product here and then put it on the shelf for 3 days and deal with the waste. If you're out, outside of Salt Lake City, those centers in general do not have platelets available because they're stored at room temperature and have a 5-day shelf life. If you now can stock whole blood or cold platelets at those institutions, you can now have a platelet-containing product to help improve, save lives for patients with life-threatening bleeding. So this logistic, benefit or public health benefit is real important to understand. Safer because of, as I've mentioned before, less risk of ABO-incompatible transfusions. It's actually less bacterial contamination risk too. Again, when using components, your platelets are warm. Stuff grows in warm stuff. Bacteria like to grow at room temperature. And when they're stored cold, bacteria don't grow. And there's been good data to show that too. Now, yes, there's new guidance from the FDA either requiring multiple bacterial testing for room temperature platelets or pathogen reduction. But you can get around all that by using something that has it all in one bag. Logistic advantages. Every blood bank that I've talked to that has started to use whole blood, the techs love it. One product out the door versus 3, right? If you've ever been in the blood bank when an MTP is activated, it's chaos because they're trying to get red cells, plasma, platelets into the cooler, out to the bedside. You're on the phone kind of going, get me the blood, get me the blood. It's hard to do. One product, boom, take it out of the refrigerator, put it in the cooler, goes to the bedside. And it gets in the patient faster, even at the bedside. Those of you at the bedside, red cells, plasma, platelets, you got 1 line, 2 line, 3 line, what do I do? What have I given yet? Have I given that yet? That's over when you're giving whole blood. Come to the bedside and you give it. And that might be one of the reasons why we're seeing these associations with improved outcomes. What are the risks? Well, there's this theoretical concern about immune complexes, endothelial injury, hemolysis. It has not been borne out in the literature yet at all, and we're all looking. Waste. If you bring it into your system and if you're only using it for trauma, right, and it has a 21-day shelf life in general, because most of us are using leukocyte-reduced whole blood that has a 21-day shelf life. If you're not utilizing it, you could waste it, which is why there are programs around the country that are using it outside of trauma for any massive bleeding in Pittsburgh for children and for any MTP activation, ECMO bleeding, GI bleeding, liver transplant, cardiac surgery. The children get whole blood, trauma or not. And we're in the process of publishing that data too. So that's one way to deal with waste. You can also, within your regional system, share the whole blood between your EMS program and your hospital to rotate it so that you don't have increased waste. San Antonio has pioneered this system. It sounds like the trauma team here has been collaborating with them to learn how they've done it in San Antonio, but they have a less than 1% waste of whole blood in San Antonio because they are working together. Imagine that, right? Working together between EMS and the hospital to share the blood and rotate it so that they minimize waste. Then there's always, it's so easy to do, now you could overdo it. Okay, sure. That's a potential risk, but any good QI program starting a new therapy is going to monitor if it's being used inappropriately, right? And you don't throw the baby out with the bathwater, right? So that to me is not a very important risk. It can be mitigated. But here's just a slide to show you when you donate whole blood, right? The Red Cross and others will split it into 3 components: red cells, plasma, and platelets. When they do that, they have to put it into bags that have citrate and additive solutions within them. As a result, even though you started with whole blood, you wind up getting, when you put these 3 back together again, a product that is anemic with a hematocrit of 29%. Your platelets are now at 80,000, and your coag factors are 65%. So when you think about the 2 therapeutic approaches, this clearly is very likely one of the potential reasons why there could be a survival benefit with whole blood. With whole blood, there's just a little bit of citrate. I think I don't have it here. It's 50 to 60 mLs of citrate and the additive solution. It's actually, we quantified it in my 2009 paper, 3 times as much as you'd expect because it's 3 bags. And when we looked at just the standard resuscitation to an adult in Baghdad at the time, the 09 paper that I showed you, there was basically about 800 mLs more. And then the resuscitation to the adult, right, they got only components compared to those that received whole blood as part of their resuscitation, 800 mLs more of citrate and additive solutions that are not going to affect shock and coagulopathy, okay? If you have a patient with a very high risk of mortality from bleeding to death, you want something that is more potent and isn't diluted with citrate and additive solutions. So, you know, we spent a lot of time, maybe 10, 15 years ago, collecting data, and we did not have whole blood in the US before 2015. In 2015, the Mayo Clinic in Pittsburgh started using whole blood against AABB standards. AABB is the used to be called the American Association of Blood Banks. It's the group that standardizes or develops standards for blood banking in the country and kind of internationally. And back then, 2015, the regs or the standards said whole blood must be ABO specific. Well, there was no way any blood bank was going to have an inventory of O, A, B, and AB, right? And we said, well, the way to get whole blood to the country would be to get the ABB to agree to low titer group O. Again, going back to World War I, II, Vietnam, standards. We approached them with the data we had then. They said, yeah, we're not interested. We said, but they're like, yeah, we just think it's you three crazy guys, me, Mark, and Andre. They said, this is a niche, this is a military thing. You guys were just, I said, so you have to learn what button to push to make the candy come out of the machine, okay? All right? And Alan Doctor taught me that, Mike. All right, Alan was one of his great, but it's true. So I said, all right, well, what would it take? What do you want? Tell me, and I'll get it for you. They said, well, it's just you guys. We don't think like the smart people in transfusion medicine would agree to this. I said, fine. So a survey? We'll do it? They, yeah, sure. Go ahead, Phil. You do a survey. We surveyed 200 of the world's leaders in transfusion medicine. I mean, the cream of the crop, the biggest names out there in transfusion medicine. And of those 200, 199 signed the petition, basically, that said, we believe Group O, low titer Group O whole blood is an acceptable product to be used for patients with life-threatening bleeding. So the ABB changed their standards, not because of data, because of a survey. Fascinating, right? Talk about implementation science and knowing what button to push. But that's what we did. And from there, there has been an exponential growth in whole blood. This is just the US. This is TQIP data. 302 trauma centers. This is not including the non-trauma centers that are using whole blood now, because there is some cardiac surgical centers using it. And of these 302, 11 pediatric trauma centers in the country right now are using low titer Group O whole blood. And Katie and I were talking about this last night. Of the trauma centers in the country, level 1 pediatric, that have decent volume, there's only about 25, 30 of them. So I would say right now, most conservatively, 33% of large level 1 pediatric trauma centers in the country are using low titer Group O whole blood. So all of this data, right, from MATIC 1 and all the other data we've been producing, led us down the path to design the MATIC 2 trial. And you all will be participating in this trial here. Thanks for engaging and being willing to participate. But this trial, the Bayesian randomized multi-center phase platform trial, where we're going to both compare whole blood to components, but also compare TXA to placebo. There's great adult data. There's almost no pediatric data other than what I showed you from our prospective study, where it was actually combined with Amicar. We're going to also in this trial do very thorough mechanistic work to better understand trauma-induced coagulopathy in this cohort, and understand if there are differences in responses in different children based upon a multi-omics analysis. So we're going to be doing lipidomics, proteomics, metabolomics to not only understand the coagulopathy of trauma, but then what are the mechanisms by which these therapies work, and is there a heterogeneity of treatment effect between those that, for example, have a hyper-inflamed response to those that don't. I don't have it here, sorry, Gideon, but Gideon, who moved here from CHOP, is working here now at the university, is our pharmacokinetic expert, and he's going to be doing a thorough pharmacokinetic analysis of tranexamic acid in this trial too. And actually, we used data that he generated at CHOP to come up with the dose of TXA for this trial, which is going to be a 25 mg per kg bolus. That's it. No infusion after it, just the bolus, no infusion. His modeling data showed that that dose gave you the same amount of coverage of the TXA serum concentration than the dose versus maintenance infusion, which is logistically also very hard for people to do. There is a 2-gram max in the trial. 24-hour mortality, I didn't focus a lot on this yet. In general, we've always had 28-day, 30-day mortality, right, as our primary outcome. But as we were designing this trial, we also learned from previous mistakes. The proper trial, the ratio study, where the FDA mandated that 28-day mortality be the outcome. Proper was published, and we all said, yeah, all right, 28-day mortality wasn't different statistically. There was a clinical difference, but it wasn't statistical. But 24-hour mortality was different. And we said, well, you know, if you're studying a product that's going to stop death from bleeding, and all the death from bleeding is occurring in 24 hours, your primary efficacy outcome should be 24-hour mortality. Your safety outcome can be 28-day, 30-day mortality. But we knew the FDA wouldn't just buy that on an IND application. So I organized an NIH-sponsored meeting in DC before we submitted this to get a consensus from world leaders that what is the best primary outcome for hemostasis trials in multiple different cohorts. We did trauma, OB bleeding, cardiac, et cetera, and every group came up with their recommended primary outcome. Well, the trauma group recommended 24-hour mortality for children, 6-hour mortality for adults. FDA was in the audience. They were invited on purpose to hear. And they have now approved for the adult studies 6-hour mortality as a primary efficacy outcome for the adult whole blood studies, and they approved 24-hour mortality as our primary efficacy outcome for this trial. So again, lessons on making the candy come out of the machine, right? Before you submit your study, try to get international recommendations published, invite the FDA to your meeting, and then they sometimes listen. So here's the biggest problem, though, with the MATIC-2 study, right? The logistic issue with this study is that what do we do with the girls before we know their Rh type, right? In general, we actually, in pediatrics, almost, even with boys, give both boys and girls O-negative red cells. With whole blood, it's the same issue. But for girls, it's a potential problem, right? Because if an Rh-negative girl does get an Rh-positive red cell, whether it's in a red cell unit or a whole blood unit, she's at risk of developing alloimmunization to the D antigen. That can lead to hemolytic disease of the fetus and newborn, which can be fatal to the fetus. So clearly, we would love to avoid that. And I would love to have Rh-negative whole blood produced in mass quantities and only give it to both boys and girls. That's not reality, right? The reality we live in is that only 6% of the population is even eligible to donate group O RHD negative whole blood. So 6%. We already have a hard time getting anybody to donate blood. So now this is really difficult to achieve, what I just said, limitless Rh negative blood. So now centers around the world are struggling with, what do we do with women? Of girls, right? And women up to, the term is, females of childbearing potential. So up to 45, maybe 50 years of age. If they could get pregnant in the future, you don't want to put them at risk of alloimmunization and have a potential fetal demise occur from HDFN. But Rh-negative whole blood is scarce. And centers are now having to choose. Do they potentially expose a woman? But the data is growing that we're probably improving survival. And there's been mixed reaction across the country. Some centers will give whole blood to men with life-threatening bleeding, but they're not giving it to women. And the reason is because they're worried about HDFN, but you started the whole blood because you thought it was going to improve survival. And I'm going to show you, I guess I'm just going to jump in my brain to the next few slides. We said, you know what? Let's just ask the women what they want. Let's just, instead of us trying to figure out, what we think is better, ask the women. And we've done 4 or 5 surveys so far. Just general population of women. We've asked mothers of girls. We've asked women who have had HDFN. They all resoundingly say, I'd rather be alive and deal with it in the future. But the blood banking community who, to their defense, have had it beaten into their head. Mark Yeaser, a research partner of mine, says, like on day one of transfusion school, where they teach them first, I don't have any transfusion medicine people in the crowd, right? Day one, you get taught you must avoid, HDFN is a never event, right? And it should be if you could avoid it. But if you can improve survival, then how do you balance the two? The problem is there's not RCT level evidence yet for the whole blood, but we have to make that choice. As you're treating your patients with massive bleeding, the girls, what should they get? And the trial is going to help try to answer that question. But we can't source the Rh negative blood either for the trial. We've tried hard with suppliers. They're going to do their best. But we thought it was essential to try to understand what is the actual risk. Because right now I'm just saying there's a risk of this, there's a potential benefit. But what are the actual risk estimates? So this is work that Mark Yeaser has done, but also Rebecca Cardigan out of the UK. Mark has kind of been branded as zealot, and sometimes I am too. It's all right. Sometimes it takes passion at times. We do our best to be fair, but it's not only Mark being the one that is publishing this. Rebecca Cardigan, I think, is immune from being labeled as a zealot. And even in her analyses, very similar risks. If you go through the math, a woman has to survive, get sensitized. By the way, the sensitization rate in trauma is much lower than what we all learned in medical school, because with trauma, you have immune suppression. Immune suppression, you don't develop antibodies to the D antigen. So it's lower than what we were all taught in medical school, which is about 80%. That woman has to then become pregnant. Not every woman does. Then that fetus has to be Rh positive, and then then there's a risk of dying if those who are positive. It comes out to a 0.3% risk of fetal death for an Rh negative woman who gets exposed to an Rh positive product who has life-threatening bleeding from traumatic injury. So now this is an estimate. I know some have criticized the math here, the estimates, but it's still, others have estimated it and they've come out to the same number. So this is what we're dealing with. Then I asked Mark, okay, look at children. What is the alloimmunization risk with children? Because their immune systems change over time. And interestingly, younger children will have a lower alloimmunization rate, lowering the risk of HDFM. So again, in the trial, we wanted to try to estimate the potential risk. So in MATIC, the median age of a female was 9 years of age. We looked at that graph to kind of get where the HDFN risk would be. So for children in the study, there might be a 0.12% risk of fatal HDFN relative to the potential maybe survival benefit. In the study, there's going to be 1,000 patients. 400 will be females, as we expect based upon previous data. So only 60 out of the 1,000 will be Rh negative girls. And if you go through the math that I just went through, if you go with the adult data of 3% risk of any HDFN, of any severity, 2 girls in the trial will be affected. 1.5% risk of severe HDFN, which is either a fatal reaction or intrauterine transfusion. If you use the pediatric data, 0.12% risk of fatal, 0.07. So there may not be any girls in the trial that in the future have a fatal complication in a pregnancy. So this is important for all the centers in the trial to understand, because the centers, they're going to get to pick what their clinical practice is. There are many centers in the country that have said, we can't get Rh negative blood. Some suppliers won't even supply it. So they are forcing Rh positive for boys and girls, and they do it routinely. It's all that they have. New Mexico, San Antonio, Houston, all they get. So they, in the trial, have said, we're fine using Rh positive. But there are those that have not started using it yet that say, well, no, I'm never going to give a girl, even trial or not, Rh positive blood. So we have to stock those centers with at least 3 Rh negatives, hoping that by the time 3 units go in, we do type the girl, we know her type, 85% of them will be positive, and then we can give them the Rh positive whole blood and not mix interventions, because we don't want to spend $30 million, 10 years of my life, and to answer a question, and then we wind up with a study that is the question is unanswerable because we've mixed components with whole blood. What will happen is if a site doesn't want to use Rh positive blood if they run out of negative, then they'll go to components. So now the group that was randomized to components, to whole blood, is now getting components. There's a mixture, and then someone here will be criticizing my study because the methods were bad, and so would I. But 56% of sites in the study so far have said they would give it Rh positive if they ran out. 40% have said no. So we want sites to follow what they want to do, but it needs to be an informed decision too, right? And I think understanding the consequences of the decision is important to recognize. As I just mentioned, if we mandate Rh negative for the girls during the entire intervention period, we're going to get crossover and it's going to dilute any potential effect and we could have uninterpretable results. We are going to pause enrollment at sites that require Rh negative for girls if they don't have 3 in inventory. But what that means is we're going to enroll less girls in the trial because the clinical practice at the site is saying, I'm not doing it. I'm saying, I'm not doing the best study. So we're going to pause enrollment whenever there's not enough Rh negative, and now we're going to have less girls in the trial, which it's not following the principle of equity of care, right? We want to include girls and do it safely. And trust me, I'm not saying this cavalierly. I wish there was enough Rh negative to go around, but there just isn't, and we're kind of stuck in the middle here. Here's the survey data. I know I'm getting short on time. Plenty of publications from multiple groups on this topic. If you're interested, I'm happy to share them. I've shared them actually with the ICU team already. Moving on so I can finish, and actually I'm getting really behind now. Cold stored platelets. We've known since the 60s they have better hemostatic function. Here's a trial showing cold stored platelets in adults had better hemostatic effect. This led us down the path of designing the CHIP study. The DCC here, the DCC is here at Utah for this trial, and this is a phase 3 trial that will license cold stored platelets out to potentially 21 days of storage. We're studying this in complex cardiac surgical patients in both children and adults. This is something that I think as a community we need to start doing. We have to start doing our trials in both children and adults, and then figure out is age and effect modifier. Because what we're doing now is ineffective. It's so hard to get funding and then to study only children less than 18 years of age, which has no biologic relevance, probably whatsoever, the age of 18. We are harming ourselves in studying what can help children. So let's start doing studies in all ages and then determine, does age make a difference? We might find here that less than 2 years of age, it makes a difference or not. I think this is a better approach. All right, now getting to the fun part, and I know we don't have a ton of time left. So I've shared a lot of data, and hopefully I've communicated it's a struggle to change practice when you don't have the data you really would love to have in RCT, but the stakes are high, right? Mortality I've showed you is really high. There's potential benefit, and so it made me think, well, what goes into in my 20-plus year career, what has influenced my change of practice or my partners? And it's, what's the evidence for the current standard of care, right? When it comes to hemostatic resuscitation, there's no evidence for our current approach to transfusing children. What's the evidence for the new therapy? Is there a biologic rationale? I've gone through that. Experience, right? Often I've changed practice because somebody older than me in where I worked was like, this is how you do it, and you learn from it. So there's the other EBM, experience-based medicine. Do you have access to the product or not? Right? If it's something that you control, it's much easier for you to change practice. With blood, it goes through the blood bank, and if the blood bank isn't willing to change practice with you, it can be a major barrier. Cost, urgency, safety, and is it licensed or not? So all of these things go into changing practice. When it comes to transfusion medicine, right, I've already kind of highlighted it. You got to think about what is the evidence for your current standard care. And there is no evidence for the crystalloid component approach that we've been using for the past 50 years. We went from whole blood to components back in the 60s and 70s because it conserved blood products for patients who needed one at a time, cancer patients. But we never studied, when we changed from whole blood to components, we never studied it. And it was interesting, in transfusion medicine, there are examples where practice has changed without an RCT. Thawed plasma, out of convenience for the blood bank and also practitioners, you can now thaw FFP and keep it in the refrigerator for 5 days. By the way, the FDA has never licensed that. It's an unlicensed product. But the ABB made it a standard. So now if you have thawed plasma in your ED, right, there was no trial. We know factor 8 and 5 is reduced over time from day 0 to 5 in the refrigerator. But we all said, well, hell, I'd rather have that than crystalloids. So we've accepted it. The blood bankers have said, you know what? We can't make plasma thawed fast enough, so we're willing to do it. We've made compromises in the past, is my point. And it's interesting, sometimes we're willing to make compromises, sometimes we're not. So I think, Maya Angelou said it best, right? Do the best you can until you know better. Then when you know better, do better. And I think that's the situation we're in, not only hemostatic resuscitation, but in all areas of pediatric care. And you don't always need an RCT to change, but clearly we should be striving to achieve them at the same time. I like to take a parallel approach. Change practice when it seems appropriate, if all of the, if the stars are aligned, if it makes sense, but also work towards getting the trial done. I don't think we should be holding back on care. If a child is bleeding to death tonight, you need to do the best you can for that child based on the data you have, not the data you wish you had. So in conclusion, there's no data, RCT level data for standard care versus current new ideas that aren't new, they're old. There are independent associations with improved outcomes for the therapies that I have listed there, and trials are underway for many of these products. And again, what do you do in the meantime? So with that, I'll stop and take questions. Thank you. Sir, the sir behind you, Barry.
No, I have a question. I have a question and a suggestion. The question is, do you see any difference in trolley or taco with these people?
They're bleeding. So trolley is very hard to recognize in a massively bleeding patient. They often will have pulmonary contusions or just get ARDS from the resuscitation. So, but no, we haven't seen trolley itself been reported in taco, no, because they're bleeding to death. You'd have to really overdo it. And again, I think we're teaching people to monitor during a resuscitation and not over-transfuse. I have not seen any cases of taco in life-threatening bleeding.
I go to other antibodies, other donors, because a lot of the donors are Caucasian, others are African American, they got different antigens. So have you ever looked at that antibody, other antibodies?
Well, when it comes to the RHD or the D antigen, I'm not aware of a racial difference.
Yeah, well, they as we genotype now, everybody, obviously in the trauma situation, you're going to do the best you can. Utah is still not tremendously culturally diverse. The worst thing I've seen actually was a JK3 antibody, a KIT AB, anti-KIT AB,
Yeah.
JK AB in a Pacific Island.
Yeah.
And she got 8 emergency release units, red cells actually, not whole blood. In the ER, she was not a trauma patient, she was a uterine bleeding, and on day 3, she started dehemolyzed and hemolyzed every unit, got hemoglobin of 3 again. Spent time in our shock trauma, we got units from Hawaii and saved her the units from Hawaii. But
So, yeah.
we're not culturally reverse here. In an emergency, you don't have an antibody screen anyway. And they're dead if their heart's empty, right?
Yeah, so what I didn't say, which is important, I think, to the question, the protocol is going to require that if a girl is Rh negative and she is exposed to Rh positive product, we're going to require that she get tested for alloimmunization 3 months later. And then we'll be able to at least understand if it occurred, and then make sure she gets the right guidance to reduce the risk of HCFN in the future.
Part of that antibody development, these people later on. Not just RS antibody, but other antibodies also.
Yes, with more funding, we could do that. Yeah.
Yeah, I mean, realistically, we're Dan's actually pulling data on our RH because men knew that right?
Well, you're right. We are going to do the ABO screen, basically.
Yeah.
So we will have antigens, but we won't know if they had them before, the antibody before the resuscitation.
Yeah, you don't know when you resuscitate, but you find it, right? You
Yeah.
test as fast as you can and then you identify
Yeah.
the antibody. That doesn't mean in a crisis you actually still can give them antigen negative because
Right.
that's the time and place, but these,
Gotcha. Okay.
I don't think we see anti-Ds at the rate that has been published.
Gotcha.
Well,
I see a few more hands up. So Barry, you were next, and then we'll go around the room.
Just real quick, storage lesion, is the age of blood issue settled?
no.
No. Next question. The age in the whole blood might matter too, but we're going to analyze that.
Because it's fresher than the
Yes.
average red cell I get at my trauma center where I take all the old red cells, right? This
Back.
is freshest blood.
Back here.
So a comment and a question real quick. I'm a neonatologist, and as far as the antibody issue with the girls and stuff like that, my opinion is, you know, we often have to focus on the mom first and to not provide something that allows for improved survival for something that may happen in the future that we don't even know is gonna be there. And we manage those things much better now than we did back in the 60s and 70s and 80s. So, you know, so those.
Agreed.
You know,
Agreed.
the question I have is, within the intermountain system, we've been using whole blood for our neonates, for
I
quite a
heard.
while now. Nick and Bob Christensen in that group and Tim Barr has been, and we've had really nice results from it. This is a strange question, but we run all our stuff through the blood warmer, right?
Yeah. Yeah.
For the platelet issue,
Yeah.
does that change some of the hemostatic, most of our.
I've seen variable results. The problem is the assays that test, that the hemostatic assays themselves are flawed. So, but the practical answer is I will put cold whole blood through a rapid infuser warmer.
Hey Phil,
I'd rather do that.
we did that study over at the adult where we ran whole blood through the Belmont
Yeah,
and didn't see any difference on TEG.
yeah, but then John Hass has published it. So, but the assays are problematic. But I would do it. I think it's worth getting in
It's
faster.
better for the neonates from a warm standpoint, of course,
Of course.
but.
Yeah, and the rapidity of infusion is probably more important than any, if there was a small platelet function decrement, I'd rather get it in faster and have 5% reduction than get it in slow and have 100%.
Great.
Make sense?
Yeah.
And they're back here.
Any pushback from the transplant surgeons with the hepatic artery and whole blood in the setting of liver transplant?
So, not to me. I don't know if he, at Pittsburgh, they haven't pushed back, but I don't know locally.
In the adults, they haven't had any issue with that. I don't know about kids.
I mean, livers often, actually, to their credit now, use way less blood than they used to. Thank God for that. Because they're doing volumes of livers now in a way that's sort of, they're up 30% last year. If they do activate an MTP, which is a rare thing, our protocol in MTP is the first pack that goes out is whole blood. And so they are accepting that whole blood. There are no concerns on their side.
So for
that.
postoperative bleeding, there hasn't been concerns. Put the liver in, within 48 hours, they have postoperative bleeding. They don't worry about the hepatic artery.
Well, of course they worry, right?
They
The
always
transplant
worry.
surgeons in the
It's
room.
not been an issue.
Of course, they always worry, but they're very judicious about not using blood, and they're using it when they're bleeding.
Yeah.
And in that situation, they're probably not going to thrombose their grafted artery. And there are no reports that I've seen so far. The only other non-trauma population that I've seen is the obstetric population that the group here in San Antonio have collaborated on. And for placenta accreta, there is evidence, small observational studies, but when whole blood is used for postpartum hemorrhage, dramatic reduction in total blood products used, probably because it's a more efficient product. 2 liters less of blood when whole blood is used as part of the resuscitation compared to when components are used. We replicated that data in the trauma cohorts too, and there's a hint to the data to that also in children. So not only is whole blood potentially able to improve survival, it probably reduces the amount of blood you need. So in that paper that we published, the title was Doing More with Less, which is real important in today's age where blood's availability is hard. Yeah. Yes, sir.
Did you say all your blood is leukopoor? All your blood is leukopoor?
Yeah.
No.
Well, in
Yours.
our system, we only accept leuko-reduced whole blood because we don't wanna worry about CMV, and
Yeah.
it makes it safe in our neonate population
That's
where we
so-
would be worried
So,
about.
yeah, but to answer the question nationally, many suppliers are using leukocyte reduced with a platelet sparing filter.
Platelet.
There are centers, but that limits you to 21 days. There are other hospital systems that are using non-leukocyte reduced whole blood that has maximum platelets in it, and they have a 35-day shelf life. It's very controversial, especially it's controversial. So that 35-day shelf life gives you the ability to share it within a system and have low waste. So if you, anyway, I know we're very short on time, but that's, most are using leukocyte reduced.
Unfortunately, we are short on time.
Yeah.
But thank you, Dr. Spinella, so much for
you.
coming and for teaching us, and thank you, everyone, for joining. If you're comfortable, Dr. Spinella, feel free to stick around for any additional questions. But the claim credit code for today is 33019. Thank you, thank you.
Thank you.